as the world is changing, and it's changing very rapidly, as we get into whether you want to call it personalized medicine, precision medicine, but really as we get into biomolecular markers, next-gen sequencing, whether it be on the genetic side, the proteomic side, the metabolomic side, to your point, every patient, especially every cancer patient, becomes their own experiment, their own trial, because we will have, hopefully, these markers that will be able to dictate, drive potential care, drive the development of orphan drugs based upon biomolecular markers. One thing I want to kind of tease out before we end up here or close up here is, so we've got a couple really landmark studies that have come out over the past year. We've got this Charter trial that looked at patients who were hormone naive that presented with metastatic prostate cancer, and basically what they discovered was that the combination of androgen deprivation therapy plus docetaxel therapy, those patients, especially not only in high volume disease and low volume metastatic disease, there was a survival benefit with the addition of cytotoxic chemotherapy versus ADT alone. Then you had this very small study out of Hopkins that looked at the splice variant of ARV7, and that if patients exhibited that variant, then their ability to potentially respond to some of these newer agents, may be limited. Again, so the reason why I'm asking this is because right now we are traditional urology practices. Neil, you and a few others have, really from the urology standpoint, have been the only ones that have actively delivered cytotoxic chemotherapy within your practice. So Gary, looking at this, and again, if we say that we are going to manage these patients, we are going to be the purveyors of prostate cancer, and we know that ultimately part of this will be the administration of potentially intravenous cytotoxic chemotherapy, how do you plan on addressing that in Cincinnati?
Well, I'm going to comment on it in two different ways. We do plan to address it. We're working on it, and we don't have it now, but we believe we will probably have a medical oncologist come into our facility every couple of weeks to see patients, not because we're offloading our advanced prostate cancer patients, let's be clear, but just patients who need chemotherapy, and that will be delivered in our facility. There's a number of groups around the country now who are dabbling in this, and I don't think it's quite as rare as we think right now. I think it's emerging, and I think this will be incorporated into a number of practices around the country, more so than you might think. The other thing I want to mention, because I hear a lot of people talk about the study looking at tax plus chemo for hormone-naive patients, and I have no problem with the study or implementing that or sending that patient to a medical oncologist if that's what is necessary for the best care of that patient. But I want to remind the listeners that that's today a pretty rare patient. Most of the patients that we're treating with CRPC are not patients who are walking in with a PSA of 200 and Mets all over the place. Most of the ones that we're talking about in our clinic are those who have failed local therapy, then failed ADT, now they got a Met. So that study looks at a pretty limited segment of the advanced prostate cancer patient base, and I think those physicians, urologists and oncologists who have looked at that study as some sort of game changer, I really don't think that's the case.
Sandy, I know you are still trying to find a medical oncologist in the Baltimore area, and have had a little bit of pushback or some difficulty.
Yeah,
right?
we did hire somebody, but when we went to try and find him some coverage, we kind of got blackballed by the medical oncology community, unfortunately. But Gary, we did exactly what you said. We found that medical oncologist that comes twice a week now and sees our cancer patients that need to be seen. There's a lot of drugs, renal cancer, testis cancer. They're seeing all kinds of cancer, and the doctors have really embraced this, and she's has grown rather quickly in just the few weeks. Her patient volume has grown very quickly. It's good for education, whether they get treated or not. Look, just for our prostate center, we encourage every one of our patients, even if they're having surgery for prostate cancer, to go to our radiation center for that education. The same thing here. When you have that service available to you, it is an education process for the patient. The better you educate the patient, the better they're going to do, and that's down the line with anything. And so when we look at the availability of providing this service, just another part of the integrated care model, end of life, nutrition, financial support, psychological, all these things are part of dealing with the patient. That's what integrated care is. It is from the diagnosis to end of life, and we need to be prepared, whether we have them in our practice or we know where to send patients, that they're going to get the best care.
Raul, if I could also mention, we have a consultant that we use for holistic care consults, as Sandy just mentioned. Some of the patients really embrace this. It really fulfills a need. Nutrition counseling and other counseling really fulfills a need for them. And the other thing that we've done, and I would encourage groups to think about, is a multidisciplinary tumor board. We do have a tumor board every month where we have radiation oncology, medical oncology, and urology for our practice, well attended, with specific cases presented. So all of this gets to the fully integrated multidisciplinary model.